Hey guys, this is Dr. Shivek. Welcome to my YouTube channel. So guys, in this video, I'm gonna discuss about a very important topic from the electrolyte abnormality series, hypokalemia. So guys, what is hypokalemia? It is the condition in which when the serum potassium levels falls below 3.5 milliequivalent per liter. So what is the normal value of the potassium? So normal value of the potassium is 3.5 to 5.5 milliequivalent per liter. So guys, let us start. First of all, what is the etiology of hypokalemia? In so it is first when there is a low potassium diet. Second, when there is a non-renal loss of the potassium. So what are the different causes of non-renal loss are vomiting, diarrhea, sweating, and a large nasogastric tube aspirations. Different type of renal losses are these are the four different types of renal losses. First, salt wasting nephropathy, Cushing's disease, diuretic use, and the Bartter syndrome. So, what is the Bartter syndrome? Bartter syndrome is the inhibition of the sodium, potassium, and 2-chloride channel, which is present in the ascending limb of the thick ascending limb of the nephron. So, these are the four different causes of the renal losses. So, fourth is the redistribution. What is redistribution? So, here you can see this is the cell, and what happens like if we give the beta 2 agonist like salbutamol, then there will be intake of the inward movement of the potassium into the cell from the serum to the cell. This causes the hypokalemia. So this causes hypokalemia like beta 2 agonists like salbutamol, insulins, and the metabolic alkalosis. So this causes redistribution. So these are the four causes of four etiologies which are cause the hypokalemia. What are the different clinical features? So the patient will be presented with fatigue, muscle weakness, constipation, arrhythmias, hypoventilation, and this hypoventilation because of the muscle weakness of the chest. ECG changes will be like early changes will be T wave inversion, ST depression, and QT prolongation, and the late changes will be PR prolongation. So these are the different ECG changes associated with the hypokalemia. Very important, guys. So how will you diagnose the hypokalemia? So first of all, we will take the history to the patient, like history of vomiting, diarrhea, any insulin on the salbutamol use. So this is very important step, guys. We have to take the first of all we have to take the history from the patient. Then we go for the urinary potassium analysis. So if it is low, then we can have three causes. You can remember from the mnemonic like VSD, vomiting, sweating, and the diarrhea. And when it is high, we categorize in the two, like with metabolic alkalosis and with metabolic acidosis. If it is associated with the metabolic acidosis, we have three causes like renal tubular acidosis, diabetic ketoacidosis, and the amphotericin B use. So this is very important, guys. Let us start again. First of all, you have to calculate urinary potassium. If it is low, then we have the three causes, and if it is high, we give two reasons like with metabolic acidosis or with metabolic alkalosis. If it is with metabolic acidosis, we have three causes like renal tubular acidosis, diabetic ketoacidosis, and the amphotericin B use. If it is metabolic alkalosis, then we categorize into further two, if it is with associated with hypertension or not associated with without hypertension. So if it is associated with the hypertension, then we have three causes like aldosteronism, Cushing's disease, and the Liddle syndrome. And if it is without hypertension, then we go for the urinary chloride assessment. And if this urinary chloride is low, then we have the reason is vomiting. And if it is high, then we have two causes, diuretic use or the Bartter syndrome. Bartter syndrome, as you know, it is the inhibition of the sodium potassium chloride channels which are present in the thick ascending loop. So these are the different causes of the hypokalemia and how will you diagnose the hypokalemia. Now some special points which are very important for you guys. So whenever you correct this hypokalemia, you always give potassium chloride from the peripheral cannula, not by the central line. Oral potassium is always better than the IV. In when you give the oral potassium, one tablet of the potassium includes 8 milliequivalent per liter of the potassium. And if you give IV potassium chloride, then its concentration is about 50%, and that ampule is of the 10 ml, and this 10 ml include 20 milliequivalent per liter of the potassium. Always we have to check the infusion rate of the potassium should be less than 10 to 20 milliequivalent per liter per hour. Never give potassium chloride directly, as potassium chloride should be always be infused, should be diluted with the normal saline. And we give IV potassium chloride only when there is the severe hypokalemia. Never add potassium chloride to the isolate M. As you know, isolate M has the highest concentration of potassium, so never add both of them. And never do treatment of the metabolic acidosis with sodium bicarbonate, as it will increase hypokalemia. As you know, so metabolic alkalosis is associated with hypokalemia, so never treat the high metabolic acidosis with sodium bicarbonate. So now what is the treatment, guys? So for the treatment, IV treatment, we will take 15% of the potassium chloride, which is at a 10 ml of the ampule. We will take 5 ampules of this potassium chloride in the 1 liter of the NS, and we will infuse at the rate of 100 ml per hour. And we will stop this infusion when the arrhythmia stops and the respiratory muscles starts working. So this was the hypokalemia, guys, and it's a very important. You can take the short screenshots from the video or make the notes. So thank you, guys. This is Dr. Shivek Singla signing.